Um, Good evening all to all the participants joining us from South and Southeast Asia. Good morning and good afternoon to others joining us from other parts of the world. I'm Poornima Prabhakaran, Director of the Center for Health Analytics Research and Trends at Trivedi School of Biosciences, Ashoka University, and also Director and Head of Environmental Health at the Center for Chronic Disease Control in New Delhi, India. I'll be the moderator for this session. And once again, it's my pleasure and privilege to extend a warm welcome to everyone joining us on the South and Southeast Asia Climate and Health Responder course. Today, we'll be getting into session 8 of this course, which is going to be centered around the topic Building Resilient Health Systems, Addressing Vulnerabilities, and Enhancing Preparedness in a Changing Climate. So for those of you who have been with us for the previous sessions, we are more than halfway through this course, and we changed track a little bit today by moving from the topical areas of, air pollution, heat, nutrition, mental health, to the conversation around resilient health systems. As always, we will do a little bit of an introduction to take you through the rigors of this course rules, and then we will get into the introduction of the speakers for today. As you're all familiar now, the course objectives are to enhance the knowledge, confidence, and communication abilities of current and future health professionals concerning the climate crisis, primarily to improve population care and public health practice, and to serve as credible advocates within your institutions, communities, and in your professional roles. We also aim to equip all the interested current health professionals with knowledge and skills that are needed to educate their own institutions' learners so that the health effects of climate change and emergency preparedness can be incorporated more easily into your licensure wherever you are. Finally, we also aim to build and strengthen an agile and informed community around climate and health education, advocacy, and policy for health professionals with strong mentorship and expert support. As I mentioned earlier, we are in session 8 of this course. The topic for today is Building Resilient Health Systems, Addressing Vulnerabilities and Enhancing Preparedness in a Changing Climate. And we have a great lineup of speakers who I will introduce to you in a couple of minutes. This particular session has specific learning objectives. The first is to explain how vulnerability and adaptation assessments are used to understand individual, community, as well as health system impacts and vulnerabilities, and then utilizing this knowledge of vulnerability and adaptive capacity to explore challenges that are faced by even the small and remote health systems. 2, to identify how the risks and vulnerabilities to critical healthcare infrastructure, delivery, and supply chains from extreme weather events and other climate impacts can be inventoried. Third, to explore the comprehensive scope of climate and health surveillance, including health and non-health sector sources, infectious and non-infectious diseases, mortality surveillance, and environmental indices. And finally, to explain and understand the importance of collaboration and information sharing across departments, ministries, and agencies to support integrated and joined up surveillance and its benefits to individual agencies. So we hope that within the scope of this session, we'll be covering all of these objectives. As you all know, this will be a 90-minute session. We have one main lecture, and we will have 2 case study presentations by the time we finish the 90 minutes. At the end of the session, we will have a moderated question and answer session. Please do enter your questions during the course of this session using the Q&A option at the bottom of the screen. Also, you all know that the sessions are all recorded. Slide decks and the resources will all be provided to you on the course website. This is also well shared with all of you in previous sessions. You have to join these sessions using your personal Zoom link, and only then will your attendance be recorded. You will have to attend at least 7 out of the 11 sessions that we have in this course to be able to qualify for a certificate of participation. And additionally, you will need to attend the final exam and scores over 70% to secure your certificate. And the certificate of participation is only given to those people who are joining through the same email and your personal Zoom link. The exam will be also through the same email address. We will be sharing the link of the exam on the final day, I think, which will be the Wednesday in 3 Wednesdays from now. And the exam link will be open till the Sunday of that week, I believe will be July 20th. It'll be a 25 question, multiple choice, true or false questions, and you should finish the exam in one sitting. This brings me to the most interesting part of my role today. I will be introducing to you now the speakers. First of all, the opening lecture will be by Ms. Faustina Gomez, Technical Officer for Climate Change and Health at the WHO CRO office. The case studies later will be presented by Dr. Meghnath Dhimal from Nepal and Dr. Inoka Suraweera from Sri Lanka, who I will introduce later. For now, Ms. Faustina Gomez, I have the pleasure of introducing the main speaker. She is Technical Officer for Climate Change and Health at the WHO's CRO office. In this role, she supports countries across the region in integrating climate resilience into public health policies and programs and helping to ensure that our health systems are prepared to address the growing challenges posed by climate change. Faustina works closely with governments, policymakers, and partners to enhance climate-informed health strategies. Her work includes capacity building initiatives, conducting risk assessments, and developing climate resilient health programs aimed at safeguarding vulnerable populations from climate-related health threats. Faustina has provided technical assistance across the region through the creation of training materials and technical guidance, and has spearheaded efforts to build national capacity and advance action on key environmental health determinants. Faustina has also contributed to both regional and global climate health efforts, supporting WHO's efforts in advocating for climate action as a public health imperative. She's deeply committed to advancing the intersection of environmental sustainability and health equity, ensuring that climate policies are inclusive and responsive to the needs of communities most at risk. The floor is yours. Faustina, I'm sorry, I should stop sharing my screen, I guess.
I have already started projecting my screen, Dr. Poornima. I hope that's visible to everyone.
Yes, yeah. Yes, Faustina, we can see your screen, and yes, we can hear you as well. So the floor is yours. Please go ahead.
Perfect. Thank you. Thank you so much for that introduction. And good morning, good afternoon, and good evening, everyone, from whichever part of the world you're joining us. My presentation today will be on building resilient health systems and addressing the vulnerabilities and enhancing preparedness in a changing climate. As you may be well aware, WHO is at the forefront of this work, and I'm going to try my best today to give you a glimpse of all what we do to support countries in building resilient and low carbon sustainable health systems. So through this presentation, I'll help you understand how climate crisis is a health crisis and why health systems need to adapt and transform. And in the process, you will also get to understand the climate-related vulnerabilities in health systems and explore strategies to strengthen resilience and preparedness. I'll also be sharing examples, tools, and recommendations along the way. So in the first part of my presentation, I'll be covering the 3 key focus areas for the public health community to advance climate resilient and low carbon health. Followed by this, I'll be covering health in climate change processes and the key ways for building climate resilient and low carbon health systems. So there are 3 key focus areas for public health, the public health community to advance climate resilient and low carbon health, and this is addressing the wide range of health impacts of climate change, promoting the health co-benefits of climate change mitigation in other sectors, strengthening the climate resilience and decarbonization of health systems and facilities. First, we'll discuss addressing the wide range of the health impacts of climate change. I'm sure most of you are familiar with this diagram by now, and climate change risks to health and health systems result from a combination of climate hazards, diverse vulnerabilities and exposures. Furthermore, health systems and facilities have impacts on the environment and contributing to climate change. So this graphic here describes the health risks from climate change and the potential negative health outcomes. So health risks are understood to be a function of climate-related hazards such as extreme weather events. This could be floods, droughts, increased temperatures, air pollution, the exposure of people, places, or things to these hazards, and vulnerability factors. This could be demographic, geographic, biological, etc. The capacity and resilience of the health system also plays a key role in determining our vulnerability to climate related hazards as individuals and as a community. And this combination of climate related hazards, exposure, and vulnerability is what leads to impacts on health, including injury and mortality as a result of extreme weather events, heat related illnesses, respiratory illnesses, zoonosis, and impacts on health systems and facilities as a whole. But the positive thing here is that we have the potential to manage many of the health risks of climate change through adaptation actions and building climate resilience by reducing exposure and vulnerability. So climate change effects on health, they exacerbate inequities between the rich and the poor, and it affects countries, communities, and individuals disproportionately. So adverse health outcomes are likely to be greatest in low-income countries and in poor people living in urban areas, elderly people, children, traditional societies, coastal populations, etc. And climate change will have its greatest effect on those who have the least access to the world's resources and who have contributed to the least to the causes of climate change. So in this slide here, the top map basically shows countries and regions, sorry, in proportion to their contribution to GHG emissions, and the bottom map shows countries in proportion to estimates of per capita mortality from climate change. So it is clear that there is a mismatch, and those that contribute the least to GHG emissions are likely to face the greatest risks to health. That's what this diagram shows. And without mitigation and adaptation, health inequity will certainly increase, especially through negative effects on the social determinants of health in the poorest communities. Now, coming to strengthening the climate resilience and decarbonization of health systems and facilities, the WHO operational framework for building climate resilient low carbon health systems basically provides a practical and systematic structure for countries. And this operational framework builds on the 6 building blocks of the health system. That's at the right at the center ring, and outlines 10 components for increasing climate resilience and decreasing GHG emissions, what you see as the outer ring. So health adaptation basically involves implementing strategies to prepare for and respond to the health risks posed by climate change, aiming to increase resilience and reduce vulnerabilities. So it focuses on safeguarding public health and healthcare systems from the impacts of climate change. And examples of this could be, say, integrated health surveillance and early warning systems, which allows for prediction of climate-sensitive diseases, or climate resilient and environmentally sustainable healthcare facilities. We will be going through a number of other examples later on in this presentation, so I'll stop there. Mitigation, on the other hand, aims to reduce greenhouse gas emissions and address the root causes of climate change, and mitigation also protects health by limiting global warming and thus the adverse effects of climate change in many cases. So this could be, so what I'm trying to say here is that the health argument for mitigation action in other sectors is quite powerful. And in addition, the health sector itself is responsible for a share of global emissions, and there are mitigation actions that can be taken by the health sector on its own. So some examples would be, say, coming up with low carbon building designs, or electric ambulance fleets, or a sustainable health supply chain. So there are also adaptation and mitigation intersecting options, for example, renewable energy in healthcare facilities, or health workforce capacity building, or say sustainable diets. The health sector also contributes to GHG emissions, and this has been estimated by the Lancet to be approximately 5.2% of the world's GHG emissions. And these emissions are equal to over 500 coal gas fired thermal power plants and over 70% of the global climate footprint of the health sector. And is basically from supply chain procurement. That's what you see on the graph over here. So the graph on the right is basically estimates from the NHS, the National Health Service England. And the purple part is the largest part, as you can see, and that is the supply chain contribution from things such as pharmaceuticals or medical equipment, food and catering, etc. Next is the delivery of healthcare, which is in red or brown on this graph. And the largest contribution to emissions in this section is energy of buildings, and then water and waste, anesthetic gases and travel. Then, of course, the personal travel of staff and patients. So the key message here is that it's useful to see not necessarily the absolute or exact contributions, but to see the hotspots where the biggest gains can be made, or where to target interventions to reduce healthcare emissions. So what is climate resilient system? It is a system that is capable of anticipating, responding to, coping with, and recovering from and adapting to climate related shocks and stress, so as to bring about sustained improvements in population health despite a changing and unstable climate. So this slide here shows the conceptual framework of a resilient system, which can be applied to communities, organizations, or other systems, including health systems. And the sheer ability of a health system to recover from a climate event by strengthening the climate resilience and environmental sustainability of the system as well as of facilities by responding to is what is being shown in this graph. So we want to decarbonize our health systems and increase their climate resilience without compromising healthcare services. So health systems across the world are at different levels of climate resilience and GHG emissions. So the little dots here basically represent countries. The x-axis is health system performance, and the y-axis is the health sector GHG emissions. So ideally, we all aim for the green square in the top left corner, that is high health systems performance with low GHG emissions. And to achieve this, some countries will need to strengthen their health systems, and some countries need to focus more on reducing their GHG emissions. We will now move on to the section on promoting health co-benefits of climate change mitigation in other sectors. So many of the drivers of climate change, such as burning of fossil fuels for energy production and transport, also contribute to air pollution. And air pollution is now one of the largest global health risks, causing approximately 7 million deaths per year. 4.2 million of these are from outdoor air pollution. So global sources of greenhouse gas emissions and urban ambient PM2.5 are interconnected environmental issues, and global GHG emissions include the release of greenhouse gases on a planetary scale, leading to climate change, while urban ambient PM2.5 focuses on the local or regional concentration of fine particulate matter in urban areas, impacting air quality and public health. However, it's important to note that both issues are interconnected, as some sources of GHG emissions, such as burning fossil fuels, contribute to both global climate change and local air pollution. So there is an important opportunity to promote policies that both protect the climate at a global level and also have large and immediate health benefits at a local level. So co-benefits are defined as the positive effects that a policy or measure aimed at one objective might have on other objectives, thereby increasing the total benefits for society or the environment. In this table here, we see the number of LT-LEDs and NDCs that identify health co-benefits of national climate change mitigation policies. Now, LT-LED stands for long-term low-emission development strategies, while NDCs are shorter-term commitments for reducing emissions and adapting to climate change, and they are climate change plans as part of the UNFCCC processes. The 2021 WHO Climate Change and Health Global Survey of Governments basically found that less than 1 in 5 countries have conducted an assessment of the health co-benefits of national climate mitigation policies. That's 91% now, as per the NDC 2023 report, include health considerations. So here is a case study from Pakistan. Using tools from WHO, models show that by implementing targeted energy policy interventions, the government of Pakistan could achieve GHG emission reductions of 27.5% by 2030, eliminating up to 568 metric tons of GHG cumulatively, while preventing more than 65,000 deaths annually from ambient air pollution in 2030. Now, coming back to the 3 areas of work that I spoke about before, to support these, it is important to raise political ambitions globally, and health should be at the core of this discussion. And this is being done through a number of different processes, including COP. Health is a strong argument for greater climate action, and not only because climate change affects health, but also because tackling the causes of climate change will provide great public health and economic gains. And health argument is now becoming very prominent in the climate change negotiations worldwide. So this slide here basically summarizes the key global climate change processes. So if I have to talk about each of these circles here, so as a first step, governments perform vulnerability and adaptation assessments to identify the most vulnerable groups, sectors, and geographies, outlining the corresponding health impacts and vulnerabilities. These then inform national climate plans. So countries outline strategies to increase their resilience against climate-related risks through the National Adaptation Plan, or NAP. The HNAP is the health component of the NAP, led by the Ministry of Health. Nationally determined contributions, as I said before, they are at the heart of the Paris Agreement, limiting global temperature rise to 2 degrees and the achievement of its long-term goals. So NDCs basically they embody efforts by each country to reduce the national emissions and adapt to the impacts of climate change. And they aim to both protect climate systems and advance human health and well-being for the present as well as the future generations. So it is important that health is represented in the NDCs. And like I said before, LT-LEDs are long-term low-emission development strategies. They're national climate strategies with a time frame usually up to 2050. So the UN Climate Change Conference of the Parties, COP, is part of the UNFCCC, or the United Nations Framework Convention on Climate Change. And during COP26, for the first time in the UNFCCC process, a health program was promoted. And since then, with every subsequent COP, health has been featured prominently. The first ever Health Day at the UN Climate Summit, this was in COP28, took place in December in Dubai, UAE. It marked the first time in the 28-year history of COP that climate organizers, they dedicated a full day to the intersection of health and climate change. And the UAE Declaration on Climate Change and Health was adopted by 23 countries. I think later there were about 143 signatories, all of whom committed to climate change integration, health system strengthening, and fossil fuel emission reductions. Now you'd wonder why this matters, because Health Day elevated health from a COP afterthought to a central pillar of climate action strategy, and it built a foundation for future COPs, embedding health concerns in climate policy, funding, and the overall system planning. So, as I said before, during COP26, for the first time in the UNFCCC process, a health program was promoted, and countries at the Ministry of Health level, they made specific commitments as a part of the program. And two of the program's key initiatives were to support countries in developing climate resilient and low carbon sustainable health systems, with countries starting to announce their commitments to the two initiatives in November 2021. So the first was in building climate resilient health systems, where countries made commitments to conduct climate change and health vulnerability and adaptation assessments, develop an HNAP, and access climate change funding for health. And also in developing low carbon sustainable health systems, countries committed to set a target for health systems, net zero emissions, majorly aimed at high emitter countries, of course, who aim to conduct baseline assessments of health system GHG emissions and develop an action plan for sustainable low carbon health systems. And since COP26, a growing number of countries have formally committed to developing climate resilient and low carbon sustainable health systems. The number stands at over 90 right now, with 7 of these countries in the WHO Southeast Asia region. The ATTACH was established, the ATTACH, or the Alliance for Transformative Action on Climate and Health, which is a WHO-hosted network, was established to support countries in implementing the COP26 commitments. The ATTACH brings together countries and partners to basically realize the ambitions that they set at COP26 to build climate resilient and sustainable health systems. And the objective is to support countries in making and delivering on these ambitious commitments. And the ATTACH supports a range of activities, including advocacy, technical support, knowledge sharing, monitoring, access to finance. And for more information on ATTACH and its workings, please visit the ATTACH Community of Practice, the link for which is provided on this site. On the slide, sorry. Now, many of you might be wondering on how countries can go about building a climate resilient and low carbon health system. Let's break this down into 5 steps. Step 1 is understanding the risks and opportunities, that is, assessing health impacts and health co-benefits. The saying is that you can't manage what you don't measure. So therefore, as part of this step, it's important to assess the health impacts of climate change through vulnerability and adaptation assessments, quantify GHG emissions from the health sector, both at the national and facility level, and evaluate health co-benefits of mitigation action, example, cleaner air, active transport, etc. One of the key outcomes of this step is to build an evidence base for action that highlights both the risks to be addressed and the opportunities for health gains. Step 2 is integrate climate into health policies and plans. So resilience and sustainability must be part of national health strategies, and this includes having countries develop a health national adaptation plan, also ensuring that health is integrated into the NAPs, the NDCs, and the long-term low emission development strategies, and in ensuring key health programs such as those for malaria or maternal health or nutrition are climate informed. So why are we doing this? Because it's important that there is a roadmap to guide cross-sectoral and health-specific climate action with high-level policy alignment. Step 3 is mobilize and align financing. So as we all know, implementation requires targeted and sustained investment. Therefore, it is important that countries allocate funds within their domestic health budgets for climate resilient infrastructure and programming, and also develop proposals and access international climate finance through, say, GCF, the Green Climate Fund, or GEF, or Adaptation Fund. And also engage with the ministries of finance and the national climate focal points to prioritize health. This ensures that resources are secured to scale action and sustain momentum. Step 4 is an important step, which is on implementing resilient and low carbon interventions. So planning must translate into action at all levels, and there are many interventions that can be implemented both for the health sector and health determining sectors to address climate sensitive health risks and strengthen the resilience and low carbon sustainability of health systems and facilities. So this includes, say, for example, building the capacity of health professionals and policymakers, or integrating climate change in public health education, or building resilient health facilities, or strengthening water systems, etc. We'll be going through this one by one later. Step 5, or the last step, is in monitoring progress and strengthening accountability. So progress must be visible, measurable, and used to guide improvement. For this, we have the WHO Global Survey on Health and Climate Change, and also the WHO UNFCCC country profiles to track baseline and progress, and WHO's guidance for measuring climate resilience of health systems. So key objectives of which are to get a clear picture of national progress, gaps, and areas for continuous improvement. So we'll now go through this one by one. For step 1, which is assessing the health impacts and health co-benefits, WHO has clear guidance on the steps to conduct VNA assessments both at the national and health facility level. After conducting the VNA, the next step is in integrating climate into health policies and plans. That's what I said. And this is through the development of the health component of the NAP and integrating health in NDCs and LT-LEDs, among others. And over here, you can see examples of countries that have done this. It is important to make sure that the health sector is represented in the planning process. There are more examples in the links that are provided on the slide. Coming to climate change and health interventions, the WHO operational framework for building climate resilient and low carbon health systems basically describes how to prepare for the health risks of climate change. It provides a structure and guidance in developing plans and strategies, and it also supports health adaptation and mitigation planning in a comprehensive and long-term way, and also supports the development of specific interventions. So these are some of the guidances that are available from WHO. There is much more specific guidance that can be easily found in our website. And the WHO website also has recordings and full trainings on conducting a VNA assessment, on ways to integrate health within the NDCs, and a number of other trainings. So I urge you to take a look at these for more detailed guidance on each of these steps. The ability for countries to engage in climate change adaptation and mitigation actions is highly dependent on their financial capacity. Unfortunately, countries, many who are vulnerable to the impacts of climate change, they're often also the least able to finance the actions necessary to address these impacts. And health is a sector where demands for climate support are most frequently left unmet, like I said before. So previous reviews have indicated that only approximately 2% of adaptation funding and 0.5% of overall funding from multilateral climate finance sources is allocated to projects that explicitly aim to protect or improve human health. And close to a third, which is 29% of NDCs now allocate climate finance to health actions or plans. And this is most often allocated to health adaptation actions and building climate resilient health systems, although in some cases also it includes other actions. This is a significant increase, obviously, from 2019, when only 15% of the NDCs allocated climate finance to health. So how do we access climate finance for climate change and health? WHO supports countries to develop single and multi-country project proposals to access climate financing for health, and key climate change funding streams include the Adaptation Fund, the Global Environment Facility, GEF, and the Green Climate Fund, GCF. Now, coming to implementing climate change in health interventions, there are many interventions and the selected actions will depend on the country's context. The interventions or actions prioritized and implemented will obviously differ depending on the country's present needs and, like I said, context. So the results of the VNA assessment, including a capacity assessment, should inform the development of plans for a comprehensive set of interventions to build climate resilient health. And examples of interventions could include capacity building, and this could be interventions to build the capacity of the Ministry of Health to, say, build climate resilient low carbon health systems, or integration of climate change in the curriculum of higher education health programs. Another example is the establishment of climate-informed health surveillance and early warning systems. So WHO provides countries with guidance and support for early warning and response systems, implementation and integration into disease surveillance systems. This is also called EWARS, the early warning and response systems. So the EWARS, which was developed over 12 years ago, is currently implemented in 17 countries, and it helps predict outbreaks based on meteorological indicators, giving countries time for preparedness and response. The system can predict outbreaks up to 10 weeks in advance, identifying transmission hotspots and improving communication between national and local health authorities. It has the ability to enhance decision-making and response actions at both central and local levels. And the system has also demonstrated high sensitivity and accuracy in predicting outbreaks. And countries in our region, the WHO Southeast Asia region, like Nepal and Bangladesh, have established, or rather, I would say, piloted EWARS for climate-sensitive diseases such as dengue and diarrheal diseases, among others. So just to give you a glimpse of how EWARS works without going into details, let's assume that the diagram on the left is EWARS for dengue in a country A, without naming the country. And the gray shaded area in the diagram on the left represents the endemic channel, indicating the historical pattern of disease incidence. And the horizontal axis displays the epidemiological weeks. And the red line basically shows the actual number of cases or weekly disease incidence, and when it exceeds the endemic channel, it signals a disease outbreak. And the blue line represents a prediction which could be related to factors like temperature, rainfall, or humidity. So the dotted horizontal line that you see in the middle, it marks the alarm threshold, and if the alarm indicator surpasses this threshold for 2 consecutive weeks, it indicates an outbreak warning. In this scenario, the outbreak prediction begins approximately 10 weeks before the actual outbreak. So in this way, EWARS is designed to give more decision power to the officer at the local level, and it improves coordination and encourages engagement of key stakeholders from the central and local levels, and also facilitates easy to translate warning signals into organized response actions. EWARS also allows spatial analysis, generating risk maps for hotspots based on model analysis, and the image on the right depicts dengue incidents on week 25 in the year 2012 in country A, and the darker color refers to higher incidence rate of the disease in specific locations during this period. Another example of an intervention is support to countries in the development of climate resilient, environmentally sustainable healthcare facilities, and WHO has developed a guidance for this in 2020, which provides a whole range of interventions to transform health facilities into low carbon, climate resilient spaces by taking energy efficiency measures, integrating green spaces, managing waste wisely, among other interventions. There are four fundamental requirements for safe and quality care in health facilities in the context of climate change, and this is through interventions in the area of water, sanitation, hygiene, and healthcare waste, health workforce, energy, and infrastructure technologies and products. The guidance provides more details on interventions countries can take in these four areas with separate checklists of actions for enhancing climate resilience and environmental sustainability for each area. So this picture here is a hospital in Bangladesh. You can see that part of the building has collapsed due to the flood, and is a representation of the impact of climate events on healthcare facilities. Another intervention is the management of environmental determinants of health. And here, a number of countries have developed climate resilient water and sanitation safety plans. And these plans, they identify specific climate change risks and their potential impacts on water and sanitation systems, and also help design interventions to ensure access to safe and reliable water supply and sanitation. And this could be, for example, through infrastructure upgrade or establishing monitoring systems, etc. And WHO has developed specific guidance for the development of climate resilient water safety plans, and countries such as Nepal, as you can see on the screen, and others have adapted this and developed their own guidelines. There are a number of other interventions covered as part of the operational framework, but what I've covered so far are some of the main ones. The last step, as I said, is monitoring progress made at the national level on climate change and health. And for this, at the global level, we have the WHO Health and Climate Change Global Survey. The survey is completed by national health authorities in collaboration with other relevant ministries and stakeholders, and presents a global picture of progress on climate change and health. And other reports include the Lancet Countdown on Health and Climate Change and the WHO UNFCCC Climate Change and Health Country Profiles, which basically presents evidence on current and future climate hazards, health risks, and the potential health co-benefits of mitigation. So in summary, here is a brief reminder of all the 5 steps we covered in the presentation today. WHO has a wide range of technical guidances available, all of which can be found on the WHO website. And before I conclude, I'd like to invite everyone again to explore the attached Community of Practice website, which has a range of tools, resources, and case studies. Thank you. And over to you, Dr. Poornima.
Thank you very much, Faustina, for keeping to time, and also that wordy force. I think there was a comprehensive presentation ranging from the inequities, global inequities in the climate and health crisis, the rationale for establishing climate resilient health systems, global commitments to building those, but also, walking us through the range of tools and guidance documents that WHO has for actually doing this on the ground. And I know this is beyond, it's a implementing this is a big exercise in itself, but actually that bird's eye view of all the tools and guidance documents that WHO has is really useful. So thank you for putting all those links as well. I think we can also share them as resources with the participants. I hope you're going to be staying with us, because we will get to the questions at the end of the session. We have 2 case studies to follow, so please stay with us. Yeah, so it's my pleasure now to introduce our next speaker. The case study 1 will be presented by Dr. Meghnath Dhimal. Dr. Dhimal is an environmental health scientist with over 20 years of research, teaching, and policy formulation experience working in Nepal, Maldives, Timor-Leste, Sri Lanka, and Germany as a guest scientist. Currently, he is based in Nepal as the Chief and Senior Research Officer at the Nepal Health Research Council, NHRC as we know it. He's Associate Academician at the Nepal Academy of Science and Technology. and visiting faculty of environmental health at the Tribhuvan University and the Yale School of Public Health, Yale University, USA. Dr. Meghnath Dhimal is also elected Fellow of the International Science Council since December 2023, which is the highest honor that can be conferred on an individual by the ISE. He's highly decorated and contributes in his capacity as a scientific officer from a low and middle income country, Nepal, in multiple global conversations, as I know. And I have the pleasure of also being with him on the Lancet Commission on Sustainable Healthcare. His primary area of expertise is on environmental health, with more focus on climate change and global health. It's my pleasure to welcome you, Dr. Meghnath. Please go ahead. The floor is yours.
Thank you so much, Poornima, for nice introductions. Good morning, good afternoon, good evening, whenever you are. I am very delighted to present the case study of Nepal on building climate resilient and low carbon health systems. And my colleague Faustina has already highlighted all the theoretical aspects, global initiative, regional initiatives on building climate resilient and low carbon health systems. So for a short time, I'll just share the case study of Nepal. We all know that climate change is a public health crisis, right? And Nepal is one of the most vulnerable countries to climate change. And Nepal frequently faces the occurrence of extreme climatic events such as landslide, floods, glacier lake outburst flood, wildfire, epidemic of disease such as dengue and cholera. For example, in the right side, you can see the rapid expansion of dengue fever in Nepal. Just the first case in 2004, and after 2022, more than 50,000 cases, several deaths every year. So it clearly shows the rapid expansion by place as well as by time. And vulnerable population as well as the health facility are at high risk of climate change. And climate change will further aggravate the poverty problem. So more people will become more and more poor. This right side, second diagram shows the last year devastating flood in the Kathmandu valleys, right? And it's badly affected the slum area, including the health facilities. Since climate resilient health system development is a goal of every country, and Nepal is in front since many years, committing, starting from Mali Declaration in 2017, Conference of Party in 2016 in UK, Glasgow, and COP20 and many others. Next slide, please. I think it's not changing here.
You were sharing.
Oh, sorry. Again, I'll share because there was minor problem. Okay, no problem. Thank you. And if you see the COP26 commitment of Nepal that Faustina also shared already, Nepal has a commitment for climate resilient health systems, sustainable low carbon health system, and funding for health. For climate resilient health system, Nepal conducted the vulnerability and adaptation assessment of health sectors. And based on that, Nepal developed the Health National Adaptation Plan, right? And Nepal has already updated the Health National Adaptation Plan that I'll come back later. And Nepal has also conducted the benchmarking of the health sector greenhouse gas emission inventory. So there are the several components of the climate resilient health system. Just a moment. There are the 10 components based on the 6 building blocks of health system that Faustina has covered. So actually, these 10 components are based on the 6 building blocks of health system. That is the leadership and governance. We say climate transformative leadership and governance. Health workforce. We say climate smart health workforce. And health information system is divided into 3. Similarly, service delivery is further divided into 3. And next is the sustainable climate and health financing. And finally, climate resilient low carbon infrastructure, technology, and supply chains. In my presentation, I will just share how Nepal is working in each component using the system thinking approach for building a climate resilient health systems. And just to make it easier, so actually developing a climate resilient health system is mainly focused on two components. First one is the decreased vulnerability in the health systems, and second, increase capacity, improve choice and opportunities. And if you can increase the resilience, right, then we can transform our health system. But if we cannot develop the resilience, then our health system may be recovered but worse than before, or even might be collapsed. That's why we need to work from right now, means we need a transformative actions for building a climate resilient health system. So as I said earlier, Nepal, it was one of the member country of WHO to sign the Mali Declaration on Building Climate Resilient Health Systems. And these declarations also endorse the framework for action in building a climate system resilient to climate change in Southeast Asia region for 2017 to 2022. And because of COVID, I think it is extended till 2027. And now I'll share how we are working on each component of these building blocks. First is the climate transformative leadership and governance. We have empowered the leadership to mainstream the climate change in health-related policy and plan. And similarly, we have established the designated unit for climate change and health at Ministry of Health and Populations, and also at the Department of Health Services. We have also mainstreamed the health in the environment and climate sector policy and plan, like the National Climate Change Policy. At the very beginning in 2019, we included the health component in the National Adaptation Program of Action, NAPA, and also in climate change policy. Similarly, we developed the first SNAP in the region for 2017-2021, and we have already updated for 2023-2030. And health is also integral component of National Adaptation Plan for the year 2021 to 2050. So actually, there is a high-level political commitment to address the impact of climate change. For example, the left picture shows the cabinet meeting of Maldives to draw the international attention that small state island states are at risk of sea level rise. And Nepal organized the cabinet meeting at the base camp of Mount Everest to draw the international attention that mountain regions are at risk of glacier lake outburst flood. So this diagram shows the policy response on climate change and health in Nepal. Starting from 2007, we organized the first national workshop on climate change and health, and there are several initiatives, including the latest SNAP development, update, similarly NAP, and also the nationally determined contribution. Very recently, before the Sagarmatha Samvat, which was held in May, we also released or submitted our national determined contributions. And this is the costed action plan with the 73.74 billion. We have a SNAP, and the cost is quite low for 5 years, 7.5 million only. But our national adaptation plan for 2021 to 2050, which is costed, and it's 47.4 billion. And these are some pictures of developing the SNAP and also updating it in Nepal. For second important component in this regional health system is the climate smart health force. For that, we have developed the manual on climate and health for refresher training to health professional based on the WHO Zero training manual. And then we have provided a training at the national, provincial, and local level. And for research component, Nepal Health Research Council has developed also a manual and providing the training to the health professionals. And for the regular training, we have a National Health Training Center, which is providing the regular training at the federal, provincial, and local level using those manuals. And another important component is the health information systems. And there are also 3 components, like assessment of climate and health risks and greenhouse gas emissions. For that, we periodically update our vulnerability and adaptation assessment. And based on that, we have developed the SNAP. And next is the climate change and health research. Nepal has done several studies on climate change and health, but still they are very limited study and mostly focus on the vector-borne disease and waterborne disease. But we need to do research on the heat waves, its effect, as well as on the NCDs and mental health. Next important component is the integrated risk monitoring, early warning, and greenhouse gas emission tracking. Nepal recently completed the baseline assessment of greenhouse gas emissions of Nepal's health sectors, and which has come up with the finding 4.1%, and globally it's a 5%. Beside that, we have developed the surveillance system of climate sensitive disease in the 4 pilot districts, and we are also scaling up in other districts now. And there are the several studies on climate change and vector-borne disease, which has shown the presence of disease vector at least 2,400 meters above the sea level. And there is a clear linkage between climate change and expansion of disease vector in the highland of Nepal, including disease epidemic. And the projections show the transmission season will be increased and risks will be increased in the highlands or previously considered low or no risk districts. And these findings are also reflected in the UN IPCC report, 6th assessment report 2022. Similarly, we have done some studies on climate change and diarrheal disease, which show that for 1 degree centigrade increase in ambient temperature, diarrheal incidence will be increased by 4.4%. Now we are collaborating with the University of Oslo, and this DHS2 is the open source software used by also more than 80 countries. And now there are the climate app incorporated in the DHS2 and also modeling app. And using this modeling app, we can predict the dengue, malaria, and other several disease. And Nepal has taken the case of the dengue, and our preliminary finding that at least in 3 months advance, we can predict the epidemic of dengue in certain area at the municipality level or the district level. And there are the different options, like using the WHO US plus model and others, means even weekly, monthly, both we can do. Next is the climate resilient low carbon infrastructure, technology, and supply chain. For that, Nepal is promoting the green hospitals, and we have already started a pilot program on climate resilient water safety plans that Faustina also shared already our documents. And several rural clinics in Nepal now fitted with a solar panel to ensure the uninterrupted power supply during the extreme weather events. Priority of government on the electric vehicle purchase for any new vehicle. This is the government policy, because now we have a surplus of electricity. We are also exporting electricity. So we are promoting that. And also we have a commitment for reduction of greenhouse gas emission from health institution in 2nd and 3rd NDC of Nepal. NDC means nationally determined contributions. For service delivery, there are the climate informed health programs. So for just example, based on the finding of the expansion of disease vector in the highlands of Nepal and an epidemic of the disease like malaria in the highland, Nepal has scaled up the vector-borne disease control program in the highlands like mountain regions. And we have also signed the memorandum of understanding between Department of Health Service and Department of Hydrology and Meteorology for sharing the meteorological data for health service delivery, including research. We have climate-related emergency preparedness and management through the early warning and reporting system for infectious disease, including climate-sensitive disease like cholera, diarrhea, dengue, and malaria. And climate change aspect is mainstream in the disaster risk reductions strategy and plan. For the management of environmental determinants of health, like shared already, air pollution is a major public health problem in Nepal. So we have an air quality monitoring system for the air pollution control. And based on that, we also issue the public notice when the air quality index exceeds 300, even we close schools. So similarly, there is a water quality surveillance mechanism in place, and vector control through the environment management like source and distribution is also in place. For sustainable climate and health financing, we are accessing the different national and international funds, like from Global Environment Facility. We did a project building resilience of health system in Asian LDC to climate change, and the country of Bangladesh, Myanmar, Nepal, Timor-Leste, Laos, Fiji, and Cambodia. And now we are also writing the proposal to the Green Climate Fund. These are some progress that we have made over the last decades for building a climate resilient health system. With the support of Alliance for Health Policy and System Research, we did this assessment, and these are the findings. But in the same time, there are some key challenges and barriers that I want to highlight. First is the limited human resource, health professional trained on climate and health, and staff turnover is also very high. Second is the limited awareness on health impact of climate change. This is not only for general public, even for the policymaker. Many policymakers still not much aware about the health impact of climate change. Mostly they talk about the impact on the, let's say, water or biodiversity or other sectors. Next is the very limited or almost no funding on climate and health, especially domestic funding. So we need to access the international funding. Next important point is the lack of institutionalization on climate and health in the federal structure. Though we have a good structure at the federal government, but still we need to work for the provincial and the local government to mainstream the climate change. And next is the limited coordination and collaboration, especially in the cross-cutting issues such as climate and health. So intersectoral and intersector collaboration is a bit challenging, but also opportunity. And next, health infrastructure at risk of climate-induced disaster. Like we have many health facilities which are at risk of flood or the landslide because they are located either in the floodplain or in the top of the hills. And finally, though we have started the DHS2, which is a web-based and now digitized, but our past data are not digitized. So we don't have the longitudinal data. So paper-based reporting of climate-sensitive disease and limited time series data hinders the analysis to better understand the impact of climate change on this climate-sensitive disease. So this is my last slide. As a way forward, what we are thinking is that developing a climate transparency leadership and governments at the federal, province, and local level, because we have federal systems. We need to ensure the sustainable domestic and international financing and climate and health. We have a climate and budget code, but still health sector has a very limited funding. But we need to ensure that even domestic funding is allocated for climate and health. Next, developing a climate smart health workforce through the refresher training as well as revision on medical and health science curriculum of university is very important, because still the content on climate and health is very limited in our medical and health curriculum. So we need to revise the curriculum so that this health workforce, when come in the market, can work as a dedicated person for climate and health. Finally, ensuring the inclusion of climate change threat in the health sector infrastructure development, including the supply chain, is very important, because we have a supply chain policy, we have a health infrastructure development policy, but they have not taken address the climate threat. So that need to be addressed in our updated policy. And finally, promoting the digital health or establishing the long-term data repository could be a best option for promoting the research on climate and health. Thank you.
Dr. Meghnath, thank you so much again for that comprehensive presentation and for walking us through the Nepal experience. I think there were several first country to develop the health national adaptation plan in the region. Vulnerability assessment was done. I think the climate footprint of the health sector, and also contributing to the IPCC with the research that was done. You also illustrated the challenges and the fiscal mechanisms that Nepal adopted. So I think one good thing about this webinar is the cross learnings for countries in the region. So thank you for sharing that experience from Nepal. Please stay with us. We will come back to the Q&A after the next case study. So it's my pleasure now to invite Dr. Inoka Suraweera, another colleague from a neighboring country, from Sri Lanka. Welcome, Dr. Suraweera. Thank you for joining us. Dr. Suraweera graduated from the Faculty of Medicine, University of Colombo, and holds master's and doctoral degrees in community medicine from the Postgraduate Institute of Medicine, University of Colombo. She did her postdoctoral training at the Monash Center for Occupational and Environmental Health at Monash University in Melbourne, Australia. Currently, Dr. Suraweera works at the Directorate of Environmental and Occupational Health at the Ministry of Health in Sri Lanka as a consultant community physician, and she's the technical head of the Environmental and Occupational Health Unit of the Ministry of Health in Sri Lanka. So she's the voice who's been leading all the conversations for Sri Lanka in this space. So it's my pleasure to welcome you, Dr. Suraweera. The floor is yours.
Thank you very much, Dr. Poornima. I hope you am audible. Let me share my presentation, please.
Yeah, okay.
Well, I think you can see my presentation. Good morning, good afternoon, a very good day to all of you. First of all, thank you very much, Dr. Poornima, for that kind introduction. And thank you very much for the opportunity. Today, I will be sharing a case study on how Sri Lanka is building a climate resilient and low carbon health system. And I would like to also address the growing vulnerabilities in the face of climate change in Sri Lanka. Well, my presentation is structured around three questions. I just want to discuss why we have thought about developing a climate resilient low carbon health system, and then what is our objective, and then briefly as to how we are going to do it and how we are doing it. Well, first, we will talk about why. And as we all know, climate change is already placing huge burden on health systems throughout, all countries, through both direct and indirect impacts. So this will continue to worsen over time. And health sector operations basically contribute to greenhouse gas emissions. And on the other hand, health sector vulnerabilities will contribute to the interference with quality healthcare service delivery. Let me take you through some of these direct impacts. Especially, there are certain instances where we have understood that some of the health facilities they are at risk especially with regard to infrastructure and all, where you can see there are landslide-prone districts, so therefore health facilities in such districts are at risk directly to climate change impacts. And on the other hand, we can see sometimes when it comes to floods, where we have seen increased frequency as well as increased intensity in Sri Lanka, supply chains are affected. Especially here, the photo shows, ambulance caught in flood waters. So therefore, transferring of patients and also supply chains.
Oh, we lost you there. Dr. Suraweera, you're gone on mute actually. We lost your presentation and you are muted.
Sorry about it.
No problem. You can just go back to the last slide.
Yes.
Maybe.
Can you see it now?
Yes.
Right. Just to talk about the direct impacts, climate-sensitive vector-borne diseases like dengue is a problem in Sri Lanka, and also zoonotic diseases like leptospirosis, we have seen a rise, especially we have seen it after floods, and also natural disasters, especially increasing the intensity as well as the frequency of natural disasters. And you can see these photos and the health impacts, especially with regard to morbidity as well as mortality. Then coming back to rising temperatures and increasing temperatures, well, increased heat exposures are happening in Sri Lanka, and you can see some of these photos where it is a problem because Sri Lanka is an agricultural country, especially with regard to food production. And the one which we are very much concerned about is air pollution, especially, I think, air pollution and climate change, they are like the two sides of the same coin. So these vulnerabilities are there, and we have identified these vulnerabilities, especially through vulnerability assessments which have been conducted for the health sector. And we are hoping to do another vulnerability assessment this year to understand about vulnerabilities further. So therefore, what we saw was there is burdening of the health systems, and then health systems will be strained due to the direct and indirect impacts of climate change. And what we need to understand is healthcare facility operations, they also contribute to greenhouse gas emissions, especially worsening the climate change scenarios, and also environmental impairment. Now, dumped medical waste, this was a problem, and waste burning and incineration, still the major method of managing infectious and sharps waste is incineration. And then again, mercury pollution, pharmaceutical waste. There have been instances where there had been mismanagement, and also pathogens. Some of the photographs I would like to show that initially, when we did assessments, what we saw about the unsegregated waste, and then like the mercury waste pollution. And these are some of the incinerators where healthcare infectious and sharps waste was managed. Basically, these are not so good incinerators. And sometimes we observe that there is some waste, especially infectious and sharps waste, and other waste may be burning also in healthcare facilities. Just to talk about the food wastage, and some of these teaching hospitals, they have been wasting, I would say, food, and sometimes there had been even instances where the average food wastage was around 750 to 1,000 kilograms. And we did a WASH assessment, basically, using the WASH Fit assessment tool, the second version. And there again, we saw certain gaps in healthcare facilities with regard to water availability and sanitation related issues in healthcare facilities. Therefore, we understood that healthcare settings cannot operate like this. And of course, it's a dangerous paradox. When the health sector meant to heal ends up making more people sick. So therefore, the answer to what is building a low carbon and climate resilient health system for Sri Lanka. And I would like to very briefly explain as to how we have started that process. Well, strengthening of climate action at national level in the Ministry of Health. Why we undertook this is to create an enabling environment. I think that is very, very important, especially when it comes to the health sector. So the Ministry of Health declared a focal point. So that focal point is basically the Directorate of Environmental and Occupational Health. And environmental health unit of this directorate has been identified as a focal point. Then again, strengthen climate action at national level in the Ministry of Health. Well, I think it's very important that we identify health sector as a priority sector in almost all national documents. So there was a revision when it came to the national policy on climate change, and we managed to include a climate resilient, low carbon health system even in this national policy. Then again, now we are in the process of developing or revising the health policy and also the health master plan in Sri Lanka. And there is a lot of discussion around climate change and health nexus. So I suppose we thought that it's very important to have national level commitments in the health sector, as well as the national level Ministry of Environment overall climate change policy, so that we have a clear roadmap when it comes to the health sector. And Sri Lanka is again one of the very early countries to develop national adaptation plan, and as we have identified 9 vulnerable sectors, and health sector is one such vulnerable sector. So we developed this national adaptation plan basically 2016 to 2025. And then another revision is happening, and this is a costed national adaptation plan, including there is a chapter on health where again adaptation actions have been costed. And we have identified INDCs back in 2019, and again in 2021, NDC 2.0 and then NDC 3.0 we recently finished, and there is health sector adaptation commitments very clearly outlined for Sri Lanka. And then again, it's very important to develop the capacities of the health staff so that we need their support and the commitment. And also, when it comes to climate action, I suppose it's very important to get commitment or engagement from the community. So without community empowerment, without community engagement, I suppose climate and health action is going to be very difficult. So with that, what we did was we identified capacity development of health staff as one of the most important areas. And we have included climate and health training into basic training of some other categories like the public health inspectors, the medical officers of health, undergraduate, postgraduate, and in-service training. And we are developing training of trainers. We have conducted training of trainers workshops and developed trainers throughout Sri Lanka, especially in 25 districts. Also, we are into developing a low-carbon, climate-resilient health system. So basically, as I mentioned, healthcare waste is an area where we need to highlight a lot. And then for that, we have developed healthcare waste management guidelines, manuals, and then training has happened around Sri Lanka. And last 2 years, we have trained around 1,500 trainers in all 26 RDHS areas, basically 25 districts. And then we have developed a national plan on healthcare waste management, where we have focused on non-incineration techniques as well. And from these provincial action plans on healthcare waste management has been developed, infrastructure developments have happened, and non-incineration techniques especially has been introduced. And there is a pilot project which is going on with support from UNDP and JET7 to introduce non-incineration method when it comes to infectious and sharps waste management, basically in 2 provinces in Sri Lanka. And we are in the process of developing guidelines for green, healthy, and safe healthcare facility conversions, or like building green, healthy, and safe healthcare facilities, where we are considering all these areas, especially energy efficiency, water footprint, food footprint, because basically in Sri Lanka, nobody has to, in the government health sector, at the point of service delivery, nobody has to pay anything. It's being borne by the taxpayers' money from Sri Lanka. So therefore, there is some kind of food wastage, and we want to address it. And climate resilient wash, healthcare waste management, sustainable consumption, green cover, building health staff, health and well-being, because health staff is going to be very vulnerable in the face of climate change, climate resilient infrastructure, disaster preparedness, as well as digitalization. So considering all these areas, we have started developing guidelines to make healthcare facilities into green, healthy and safe facilities. And just to very briefly mention about further action, we have started GHG emission studies, especially to in healthcare facilities, and climate resilient wash standard development for health sector has been commenced, and negotiations have started to secure funding from from donor agencies, and also from the government of Sri Lanka. They have started funding for the health sector in terms of climate action. I think it's very important that we build climate resilient and low carbon health systems, not for anything, but just to give hope for better and healthy living for them. Thank you very much.
Thank you, Dr. Suraweera. You couldn't have ended in a more, compelling note that we need to leave a healthier future behind for our children. Thank you so much to all the speakers. I will now move to the Q&A. Our audience has been very, very attentive and posting a lot of questions, so it's going to be very difficult to address all of them, but I'm going to start with Faustina and move to Dr. Meghnath and Dr. Suraweera. If you can just give crisp answers so that I can direct more questions if I can. So, Faustina, there's a question from one of the participants asking, you started with this inequities in the climate and health crisis. Why are LMICs affected the most, although we produce less greenhouse gas emissions? How can we address this inequity? Basically, do you want to take that?
Yeah, sure. Thank you for that question, Dr. Poornima. So that's a good question, actually. So LMICs basically contribute less than 10% of historical GHG emissions. But yeah, as you said, they're most exposed due to the geography or dependence on climate sensitive sectors. This could be agriculture, and also because of under-resourced systems. And how can we address this? So addressing this basically includes scaling up climate financing, as I mentioned in my presentation. There is opportunity to enhance South-South collaboration, come up with locally led adaptations, and among other things, obviously advocate for loss and damage funding under the UNFCCC frameworks. So that's something that I could think of. I'm sure the other speakers can add more to this. Thank you.
No, I know. I mean, that's a thing that resonates with all of us. Why us? But I guess it's a legacy thing. But I think there's so much of cross learning here itself for us to kind of hand hold each other to address this issue. I'll get a couple of more questions for you. So, how can rising political ambition for health in climate policy be translated into legally binding frameworks that prioritize vulnerable populations like children, elderly, and indigenous communities? So, political ambition on the one side, but how can we actually translate into legally binding frameworks? Any thoughts on that?
Is this question still for me?
Yeah, for you, yes.
Okay, all right. Good question again. So, like I said, I think this can be done by integrating health. This is something that WHO has always been advocating for, integrating health into NDCs and climate policies and strategies. We can come up with legal instruments to protect the rights of the children, the elderly, and the indigenous community under different environmental and health laws. And also there is opportunity to include equity-based indicators within existing national climate change and health monitoring frameworks. These are things that I can think of immediately. The other thing, obviously, is by integrating this within the overall health and all policies at the national level.
Yeah, thank you. I think that was a tough one, but I guess legally binding frameworks notwithstanding, I think in the adaptation responses at country levels, we can certainly think of addressing all these vulnerable groups that we always tend to group together, because I think the adaptation response for young children, elderly, pregnant are all very different, and I think ungrouping. I will give you one last question and then move to Dr. Meghnath. So you talked about the early warning systems, right? So there was a question from a participant asking, how does the EWARS that you presented differ from monitoring disease patterns in routine IDSR, I guess that's integrated disease surveillance, data patterns over time? How is it different? So you want to take Faustina, again, that was a question to you.
Sorry, I thought you said Meghnath.
No, I will. So how does the EWARS that you presented differ from
Okay.
monitoring disease patterns in routine IDSR? What country that is?
That's a very tricky question, by the way, but I'll try and answer that. So I think IDSR does not track emerging outbreaks, and that's not the case in EWARS. But the other speakers can correct me if I'm wrong. It's possible that Meghnath might have a response to this.
Dr. Meghna, do you want to take that? And then I will, specific question that was posted for you, I will come to that. EWARS and national disease surveillance systems.
Yes, thank you so much. Actually, all the country have the surveillance system in place. That is the regular, but early warning and response system is bit specific to the infectious disease, like for cholera, dengue, malaria, etc. And there is a weekly reporting system in all the member countries. And WHO has developed the US Plus tools. So using the climate data, we can predict the disease that the Faustina has just shared, right? And now the other group like University of Oslo and other are also taking it, and now they are making the models so that we can predict the other disease also. So this early warning system is very useful, especially for the containment of the epidemic in the future.
I guess disease surveillance systems are, I mean, the continuous kind of documenting of,
Yeah.
within the system, surveillance
Like, for
mechanisms.
example, surveillance for non-communicable disease state survey, right? We do in every 5 years. But this or US is weekly data reporting. Even some country do the daily, and based on that, we can develop the signals of the epidemic of the disease, so that we can prepare on time and we can avoid the epidemics. That's the basic idea.
Predicting hotspots, maybe, that
Yeah.
and that feed into preparedness mechanisms. Faustina, and thank you, Meghna.
Yeah, I think IDSR basically tracks disease patterns over time, like you rightly said, and they tend to miss the emerging outbreaks. Whereas EWARS, the focus is specifically on emerging outbreaks, and it also ensures that it gives warnings on time so that public health action can be initiated. So that is the difference between the two.
Thank you. So, Dr. Meghnath, you talked a lot about training. So, there was a specific question to you asking how have you developed this climate smart health workforce through refresher training involving universities in Nepal? If you want to say something more about that, the
Yeah,
mechanism.
thank you. Yeah, so developing a climate smart health workforce is one of the key component of building a climate resilient health system. So accordingly, we have already introduced the climate and health course in the Kathmandu University in the public health program. Also, they have introduced the planet health program, and the Trivedi University has also revised the curriculum. So that has already started. So one of the achievement of Nepal, but still we need to make up more courses which is dedicated, let's say, for elective course or something. So that is the plan. Second, those health professionals who are already working in health service, we provide the refresher training after after the selection from the public service commissions, like 1-2 hours we at least cover for climate and health. And third one is that focusing to the program like the malaria program or dengue program or the nutrition program, we select the participant and we provide the refresher training on the climate and health. And for this training, we have developed the manual for the policymaker also. So we have like half-day orientation program. And for the mid-career professional, we provide like 3 to 5 days training. And also at the grassroots level, like the female community health volunteer or the health professional working in the local level, we have also separate manuals. So using this manual now, different training are going on, right? And some are just supported from WHO, but now some municipality, provincial government have their allocated their own money, and they are also continuing such trainings. So that is the idea for developing a climate smart health workforce. And beside that, like Nepal had no like heat waves, but our studies show that Nepal is also at risk of the heat waves. But our health professional may not have the idea how to manage, for example, heat stroke, right? So there are also now guidelines being developed. We have the heat and health action plan, and clinical guidelines are also being developed, like how to manage the cases of like the heat stroke, right, and others. So in this way, not only from the preventive aspect, also from the curative aspect, also we are developing the climate smart health force in the country.
Yeah, thank you so much. I think this is an important area to address for all of us. I mean, we have here somebody from WHO and then from the Nepal Health Research Council and then Dr. Inoka from the Ministry of Health. It takes a bunch of different forces to actually integrate climate and health education, whether it's the universities or it's for the public health practitioners or the ground or the future medical doctors, the medical students. So I think it's happening in different parts of the world, and I think we all can join hands in taking this effort forward. Dr. Inoka, do you have something to share? I mean, you also mentioned how Sri Lanka approached this, and I think bringing it from the Ministry of Health, it cannot be one size fits all. I think what works in Sri Lanka may not work for us in India, but could you want to share some of your experiences, how you did this?
Thank you very much, Dr. Poornima. I think it's very important to capacitate, especially the health workforce, in this area, climate change and health. As mentioned by Meghnath and Faustina, I think it's important to cover everyone. So basically in Sri Lanka, it has been incorporated into undergraduate studies, especially for medical faculties, and also especially courses like community medicine, public health, for MScs, that is postgraduate studies, and even medical administration. So they talk about climate change. I suppose it's very important because at the end of the day, even administrators, they need to understand the importance of building facilities as climate resilient and low carbon systems. So then again, what we have done is basically we have targeted, as mentioned by Meghnath, both curative as well as preventive health staff. In Sri Lanka, of course, we have a structure where we can address these issues at grassroots level, especially even targeting communities. And we have started this training for the preventive health staff. And as I mentioned, we have developed a 2-day course to develop the capacities of the medical officers of health as well as the public health inspectors. And of course, we are doing this training in all districts because it's very difficult to sort of cover these things, especially like all parts of a country. But we are fortunate, I guess, because we are small and an island. So therefore, we are developing the capacities of district level staff, and we have advised them to further have this training so that basically all public health staff, they are aware, and then what actions, adaptation, mitigation, and how they can contribute to climate change and health action. And why we are doing this is especially we need the support of the people. So getting communities engaged and to empower communities, I suppose we are getting the public health staff, the capacities, updates of capacities for public health staff, and that is how we are doing it in Sri Lanka. And as mentioned, we are developing these clinical guidelines, especially for curative health staff, because we have identified some of these activities, especially in the National Adaptation Plan, a revised one, as well as in the NDCs. So targeting everyone is very important, and especially to target the communities for their empowerment and getting their engagements. That's what we are doing in Sri Lanka. Thank you.
Thank you so much. I would have, loved to keep engaging you, but unfortunately, we're run out of time for the session. But I do want to, conclude by saying, I cannot summarize all that you all have shared. They were excellent presentations. But just to say that this is such an important part of the climate and health response in our region, especially for the South and Southeast Asia region. I feel this is a platform that has brought together a lot of learnings and best practices, whether it's health national adaptation plans. I mean, I heard Sri Lanka health national plan for waste management, healthcare waste management. So I think this is just a beginning, that we are now aware what is already there in our region. And it's for us, I think, to kind of pick up all these pearls that we have picked up in these courses and the sessions that we have had so far, and I'm sure in the remaining 3 sessions to come. But I do want to say thank you to all of you, Faustina Gomez from WHO Sierra office, Dr. Meghnath Dhimal from Nepal Health Research Council, and Dr. Inoka Suraweera from Sri Lanka Ministry of Health, for sparing your time to come and share your valuable knowledge and insights with this audience. Thank you too to the organizers, the Mailman School of Public Health GCHE program, I think, for steering all of these efforts. And thank you finally to the audience and the participants. I think you'll have been a wonderful audience. Session after session, we are seeing the deep engagement and the thirst for learning. And I think this course is only just guiding you to all the different resources, but it's a conversation that has to keep going for the region and for addressing the climate and health crisis in the region. Thank you so much, and we'll see you in the next session a week from today. Thank you, all of you.
Thank you so much.
Thank you.
Thank you.
Thank you. Bye-bye.